Hi everybody, this is Professor Mbewe, and we are going to continue our discussion on some of the GI disorders that we may encounter. Once again, I would encourage you to pull up your GI assessment PowerPoint, and this time you'll be focusing on the gallbladder, and you're looking at the whole anatomy and physiology, and you're focusing on, how is a gallbladder situated in comparison to the liver as well as in comparison to the pancreas, and what are the main components that you should be caring about at this point. All right, so when you look at your A&P and you look at the slides from the GI assessment, you're going to remember that we talked about the gallbladder, and we talked about the fact that the main feature for the gallbladder is that it's actually supposed to be storing bile, right? And we also remember that we talked about the fact that one of the major jobs for the bile actually is for emulsification of fat, and that it also helps with digestion. So there's a structure known as the sphincter of Oddi that is present, and normally when you're eating food, that sphincter of Oddi is closed and the bile is basically being stored and put away. When you're done eating and the food has traveled and it's gone down to your duodenum, your sphincter of Oddi actually relaxes, and then it allows all the bile to basically join the byproducts of digestion in your duodenum. And the whole idea is that once that bile connects with the byproducts of digestion, basically then the bile can do all the job that all the different chemical breakdowns that it's supposed to do. So that includes breaking down your fats and helping with making sure that the products of digestion are basically broken down accurately. So and all of this is mediated by the hormone known as CCK. So it's I think it's cholecystokinin, cholecystokinin. So CCK mediates the release of bile basically by opening up the sphincter of Oddi. And then you're going to look at the pancreas, and we'll talk about the pancreas when we get to pancreatitis. So just remember some of the exocrine and endocrine functions of your pancreas. All right, so you're looking at this picture closely once again, and you're looking at, you're looking at all the important features that are present here, right? So that includes the gallbladder, right? From there you have what is known as the cystic duct. And then you are looking also at the pancreas as an organ, and then you're paying attention to the pancreatic duct, because that becomes important under pancreatitis. And you're also paying attention to key words like the common bile duct, where they're basically meeting, and you're paying attention to the how the duodenum is situated as well, right? So this is where everything basically ends up at some point. So all of this will make sense as we get along. All right, so just some terminologies that you should be aware of, some terms that you should know. So cholelithiasis is basically just stones in your gallbladder, and that's usually the main reason why we're getting problems in terms of the biliary system. It's usually because of some type of stones that have formed. And then choledocholithiasis is stones in the common bile duct. And then cholecystitis is inflammation in the gallbladder. And a lot of cholecystitis is usually because of some stones that have formed. That is the main reason why people are ending up with things like cholecystitis. All right, so cholecystitis is inflammation of the gallbladder, and it can be acute or chronic. In terms of the manifestations you're going to see, so you're going to see things like pain, tenderness, rigidity of the upper right abdomen, and this can also radiate to the mid-sternal area or the right shoulder. You may also see things like nausea and vomiting, and if the gallbladder becomes filled with purulent fluid, Maybe in addition, there's an infection that's happened, or there's a blockage that's happened, and it's sitting there for a while. Then you're going to end up with things like empyema. All right. So just be familiar with the term empyema. So just know that it's basically purulent fluid that's accumulated. All right. So when we're talking about the stones, um, we call them calculus. All right. So with cholecystitis, it can either be stones are causing it, or it can be acalculous, meaning that you don't have stones, but still the patient has a cholecystitis. So when it's calculus, you know that it's a stone that's obstructing the outflow. Um, so once that happens, the bile that stays, right? So you have a stone that's basically obstructing the bile outflow. So the bile that's not able to move forward. So you're looking back at your structure, you're looking back at your anatomy and physiology picture again. You see where the gallbladder is, and you see that there is what is known as a cystic duct there, and so basically the bile is supposed to move forward, but now that's not going on because for whatever reason there's a stone there. So unfortunately what happens is the bile that stays basically initiates a chemical reaction. So you're going to get, because remember the bile is for digestion, that's what it's supposed to be doing. So now you're going to be getting weird things like autolysis that are going on in a place where it's not normally supposed to be going on. You're getting edema formation. Your blood vessels are basically getting compressed, and all of that is compromising your vascular supply. So unfortunately, you can end up with things like gangrene if the situation really exacerbates, and you can even end up with things like perforation. So that's why we don't like stones forming and obstructing the outflow. All right. With acalculous cholecystitis, so this is inflammation with the absence of stones. So there are many different things that can cause this, and don't overthink any of this. Just know that these are other things that can cause it. So things like trauma, extensive burns, maybe you've had surgery and they've manipulated the gallbladder itself, cystic duct obstruction for other reasons. Maybe there's twisting or torsion that's happening. Maybe there's infections. Maybe it's a reaction to multiple blood transfusions. Any of that can be a problem. So they're not 100% sure why this is going on again, but they're basically saying that basically you end up with alterations in the fluids and electrolytes, and you're ending up with alterations in the circulation. So the biostasis that happens also basically creates the same issues that we talked about earlier. All right, so in terms of bacterial organisms that can cause a problem, so you have things like E. coli, you have streptococci, and Klebsiella. So all of these have been implicated as well. All right, so we're talking about the stones now. So get familiar with words like cholelithiasis. So just get used to that. So you know that they can vary greatly in size, shape, and composition. We've been told that they actually are very uncommon in children and young adults, but they do become prevalent with age. So you have some statistics here, and you don't have to memorize these, but 50 to 20% of women between the ages of 20 and 55 years of age can get stones, and then also 50% of women by the time they're 70. So just know that this is out there and can happen. And then prevalence in men, approximately 1/3 to 1/2 the rates of occurrence in women. So just know that this is a possibility. All right, so the key mechanism as to why the stones actually happen is that there's supposed to be a balance basically between cholesterol, bile salts, and calcium. So that balance is no longer there, it's altered. So what you end up with is you end up with precipitation. There is a slide that I have later on that kind of goes more in depth, trying to explain why this is going on. And primarily they'll describe them as being two types of categories. So they'll either describe the stones as being pigment types of stones or cholesterol types of stones. Those are like the two main ways that they'll describe this. So apparently this alteration can happen in particular groups of patients. So patients maybe with cirrhosis, patients having some type of hemolysis, and patients predisposed to infections of the GI tract. And so the main mechanism, especially with cholesterol, is that the bile becomes supersaturated with cholesterol because that cholesterol is not being broken down. So you're getting things like precipitation, and eventually you're getting cholesterol stones. So that is definitely true when we're talking about the cholesterol types of stones. And then the other components is the bile salts, the bilirubin, the calcium, the protein. All of these can happen in terms of the alterations in just how all of this is getting broken down, or maybe you're not getting enough bile salt synthesis, so therefore now you're getting other pigments that are increasing because they're not breaking down different types of different components of digestion as well. So you can also have, so they'll talk about them as being pigment stones, cholesterol stones, or they may talk about them as being mixed types of stones as well. For your purposes, at least to just be able to understand pigment versus cholesterol for now. So we've mentioned the fact that stasis of the bile can lead to gallstone formation. So things that basically would increase stasis of bile, right? So things like immobility and pregnancy, maybe if you have some type of obstructive lesions, right? So where things are not being able to move forward, the bile is not able to move forward and sitting around. So that can also be an issue. So here we're just talking about stones. So initially we talked about cholecystitis and the different things that can cause cholecystitis. So we mentioned the fact that you can get cholecystitis from having stones, and we mentioned the fact that you can get cholecystitis from other conditions, and those have nothing to do with stones. But here specifically under cholelithiasis, we're just talking about stones in general, and the fact that you can get stones basically when you have an alteration in the pigmentation, in the cholesterol, in the calcium, even maybe the protein levels, and that's why we're ending up with stones. So don't get confused with your terminologies as you're going along. All right, so here, this is a slide that basically tries to talk about the types of stones that you can get, and so he's talking about one of them as being pigment and the other one as being primarily cholesterol. So here you're getting unconjugated pigments in the bile. They're basically they precipitate and they're forming stones. So remember we talked about conjugation earlier, how things are supposed to basically get broken down, right? And then they get excreted like they should. So things are not getting broken down here under unconjugated. They're not getting separated like they should be. So this is the smaller amount of the stones that have to do with unconjugated pigments, and apparently it's only about 10% to 25% of cases in the United States. They've specifically connected these to having to do with cirrhosis, and that makes sense because we talked about cirrhosis and we talked about how conjugation may not happen, so that would make sense. And they've also mentioned hemolysis and infections of the biliary tract, specifically under the pigment types of stones. All right, and then let's see, under the cholesterol, they're saying this accounts for more of the stones. So they may describe them as being at least 75% in some cases. They're specifying under the bullet number 3, but it's primarily because of decreased bile acid synthesis and increased cholesterol synthesis. So decreased bile synthesis and then increased cholesterol. So that's why you're getting a lot of cholesterol formation, basically. You're getting the supersaturation with cholesterol, and then you're getting the formation of stones. With that, you're getting the inflammatory changes that happens. And don't worry about the stats in terms of women here versus men. But I would want you to know that stone formation is more frequent in people who use oral contraceptives, and estrogen or clofilbrate. So clofilbrate there's a definition for this. Give me 1 second. It's not even important, but it's something that I'd looked up. Anyway, so they're saying it's an anti-lipidemic medication. So you're more susceptible here to having cholesterol formations. So they increase cholesterol saturation. All right. And really, that's the main thing that I would highlight on this slide. There's also an increased risk of malabsorption because of bile salts in patients with GI disease. And I'll talk about the T-tube later on in terms of some of the treatment. So main takeaways under cholesterol, you're getting decreased bile acid synthesis, and you're getting increased cholesterol synthesis. That's why you're getting the supersaturation of cholesterol, and you're getting the stone formation. Also, contraceptives, oral contraceptive, estrogen, and medications that are clofilbrate that are used to basically, it's an anti-lipidemic, so it's supposed to treat the lipids, but unfortunately you get a side effect of having increased cholesterol levels. So once again, you don't need to memorize this either at all. And then that's really the main takeaway over here. All right, so stones vary depending on acuity. They can be silent, producing no pain, and you only end up with mild GI symptoms. And in some patients, you just move the stones and nothing happens to you. All right. Unfortunately, some of these symptoms can be acute or chronic, and so these can be described as epigastric distress, foodness, abdominal distension, and vague pain in the right upper quadrant of the abdomen as well. And apparently this happens a lot after a patient has had a nice fried fatty meal. All right, if the gallbladder obstructs the cystic duct for sure, and then the gallbladder becomes distended, inflamed, and eventually infected, that can cause what is known as an acute cholecystitis. The patient can have things like a fever, they may have a palpable abdominal mass, they may have biliary colic with excruciating upper right abdominal pain that's radiating to the back or the right shoulder. This biliary colic is associated with nausea and vomiting, and apparently it happens after a heavy meal, so 3 to 6 hours after eating. Apparently the patient becomes very restless. They're unable to find a comfortable position. For this pain, in terms of management, they do not like morphine. Apparently can cause spasm of the sphincter of Oddi, and they will use Demerol instead. However, they are saying that even though they're using Demerol, still some of the metabolites of Demerol can be toxic to central nervous system. So this is something that's probably going to keep changing depending on the different studies that they're doing. I am pointing this out though because you're going to see that when we get to pancreatitis, the medication of choice becomes Demerol and not morphine. I'm sorry, it becomes morphine and not Demerol. So here, under gallbladder, the medication that we are using is Demerol instead of morphine. So even though we're using Demerol, they're still just saying that, okay, yes, you can use your Demerol, but they're saying that even if you're using Demerol, you have to use it cautiously because it can be toxic to central nervous system. And then also Demerol has been known to be a little bit crazy for older patients. Like they start hallucinating, they think they see things. So you just want to use it very cautiously either way. That's the main takeaway from here. So if your gallstone continues to obstruct the duct, then things like abscess, necrosis, and perforation, and even peritonitis may result. So these are the main takeaways from here. All right, some patients, if the bile is not going where it's supposed to be going because it's been obstructed, not going to the duodenum, then you're going to get a patient that's going to get that yellowish skin color, right? Because some of it is being absorbed by the blood, and you're getting the color of the skin changing to yellow. Okay. The changes in the urine in the stool color. So some of the bile gets excreted by the kidneys, and then they're going to have a dark color in terms of the urine. And then The feces, however, will be getting like a putty or a clay-colored color because the bile is not advancing like it should be, right? It's not moving along like it should be in terms of your digestion. And then for your vitamin deficiency, so remember what bile is also supposed to be doing. So then you're going to get alterations in your fat-soluble vitamins, in particular A, D, E, and K. So then this will definitely not be a problem for your patient. Will definitely be a problem for your patient. So maybe some patients will have bleeding tendencies because you need vitamin K for normal blood clotting, and that is no longer happening. All right, so your diagnostic tests, you are going to be educating your patient about what to expect and your possible side effects. So some of these tests are abdominal x-rays. Know that they have this radionuclide imaging that can be done. So this is a radioactive agent. It's given IV. And then they scan the biliary tract, and they're basically looking to see where the stones may be, right? So they could do this as well. But we don't like the fact that we're using a radioactive agent for this one. Your ultrasonography or your ultrasound is still your kind of the diagnostic procedure of choice. So apparently it's effective in detecting 90 to 95% of stones. And it's awesome because then we don't have to worry about using any contrast medium, and it's not invasive, right? So we can do this as well. And then also your ERCP, so that's another test that they can do. So they're looking at your gallbladder, cystic duct, common hepatic duct, common bile duct, and it's basically just looking at all of these different organs. Unfortunately, with the ERCP, you're monitoring for complications, and they include things like pancreatitis, perforation, bleeding, and infections. You're doing your vital signs, and the patient definitely has to be NPO until your gag reflex returns. So this is definitely much more involved than, let's say, an ultrasound, and the complications are that much more. And you're doing the usual things in terms of consent, making sure that's there. And then the other test can be a cholangiography, percutaneous transhepatic cholangiography, also known as a PTC. So also helpful in locating stones within the bile duct. They're not using it as much because of the other tests actually are just as good. Your other tests, looking at your WBCs, you're looking at your liver function studies, and you're looking to see, what's going on with your bilirubin in terms of your assessment. Okay. And that nice word here for direct is basically looking at how well your liver is conjugating, right? And you don't have to remember this either, but you're looking at how well the liver is conjugating, and is it clearing your bilirubin like it should be? And the indirect, it's unconjugated, meaning that it's not broken down. So you're looking at all of those different factors. All right. All right, so in terms of your treatment for cholecystitis, so remember it's an itis, inflammation, pain control is going to be a big deal. If it's caused by things like bacteria, etc., antibiotics are going to be involved in some way. You're looking at your fluid and electrolyte balances as well. In terms of your stones themselves, so different types of procedures can be done. One of them happens to be an endoscopic sphincterectomy. So they're going to widen the sphincter of Oddi, right? If that is the issue. Because remember, some of it can happen because of either torsion or twisting that's happened, or maybe there are stones there even. So we have to figure out what we need to do. They can also do extracorporeal shockwave lithotripsy, ESWL, and this one is not being done as much, but I still would like you to be aware of it. It's been pretty much replaced by a laparoscopic cholecystectomy, which we're going to talk about. So for this one, I think there's a slide that explains this information later on as well. So either they use a bag that's filled with fluid, they put it next to the body, and then they basically shake the fluid next to your body in the hopes that they can break down the stones, or they can immerse the whole patient in water, and then they do it that way, and the water shock waves basically try to dislodge the stones. So probably not seeing this as much, like I mentioned, because they're doing a laparoscopic cholecystectomy more. Or they can also do medication. So these are medications that dissolve the stones. In particular, one of the ones that we like to ask you about is Actigall, and you may see this on your when you're doing practice questions. And then, of course, analgesics and antispasmodics as needed, depending on what's happening in your patient. All right, your medical management, essentially, you want to treat the pain with either a supportive and dietary management. You want to do endoscopic procedures or surgical interventions if you have to. So I mentioned earlier that lithotripsy and dissolution of gallstones are not being used as much because they're temporary in terms of solutions. So now we are basically doing the laparoscopic cholecystectomy. That's our go-to. All right. All right. So 80%, that's a pretty high percentage number of patients that have acute gallbladder inflammation. They do get remission with rest, IV fluids, nasogastric suction, analgesia, and antibiotic agents. So normally we do not need to be doing surgical interventions. So we're only doing that if obviously the all of this stuff in the first bullet didn't work, and if the patient is in the acute stage, we are not going to do the surgery. We're going to wait until at least some of the acute symptoms have subsided. And so our go-to now is a laparoscopic cholecystectomy. After they've had that, usually whatever you're going to advance the diet as tolerated. Of course, they're going to be NPO initially, but then you're going to advance the diet as tolerated, and it's most likely going to be low fat, no matter what it is. Low fat liquid, low fat regular food, whatever it is, it's low fat initially, and then you can kind of advance accordingly. Once again, patient specific, so high in protein, in carbohydrates. So everything you want it to be non-gas forming vegetables, right? So rice, lean meats, mashed potatoes, non-gas forming veggies, nothing that's going to hurt your belly really. And then you're going to advance everything as tolerated. So no eggs, cream. Well, I shouldn't say no. I'm going to say avoid. Fried foods, cheese, rich dressings, gas-forming vegetables, and alcohol. So you want to avoid them as much as possible. Your book will say that there's really no restriction necessarily in terms of fat, but most patients do not do well with fat. So once again, you have to be patient-specific and see how they are doing. All right, so low-fat diets, more frequent meals as tolerated, and you're going to maintain them on an NPO status until you're getting, bowel sounds, etc., and then you advance to clear, and then you progress as tolerated, as always. All right, these are some of your medications, which I mentioned earlier. And once again, not treatment of choice because the gallstones tend to recur. All right, this is the slide talking about the ESWL, which is the extracorporeal shockwave lithotripsy. Once again, not being done as much, but waves transmitted to the body through a fluid-filled bag or by immersing the patient in a water bath. So if you're lucky, once they've done the wave, the shock wave with the fluid, if you're lucky, you can just pass the stones, or they can go in there with an endoscopy, and then they could take it out that way, or they can give you some medications, hopefully, and that gets rid of the rest of it. So there's no incision, no hospitalization. They're usually done outpatient, but usually need more than one session. And we've mentioned that this is not being done as much anymore, but you may hear that it's being done in some places, who knows. And I mean, America is always more advanced than other places in the world, so maybe other places in the world it may still be going on. All right, so laparoscopic cholecystectomy. So gallbladder is removed through one of four small puncture sites in the abdomen. You have, and so that's just with 4 incisions. So they're letting you know that there's the 2 main types of cholecystectomies. So laparoscopic, 4 incisions are made, tiny ones, or it could be open, and that's the removal of the gallbladder through a surgical incision. So after a patient has had any of these, but in particular, especially if they've had like an open cholecystectomy, which is a bigger incision and a bigger surgery, sometimes they'll put in what is known as a T-tube. It's inserted. So with the T-tube, the T part, this part on the top, that's the part that is inserted. Sorry, so the T-tube, this T part, that's the part that is inserted inside the common bile duct, while the long part, this T part, the longer part of the T, is basically on the outside, is brought out of the tummy through a small cut, and then it's connected to a bag. So they're doing this because after you've had surgery, there's a lot of swelling, and sometimes you're going to get a buildup of bile. And remember what bile is. It's a digestion product, right? That basically emulsifies fat, like it breaks things down. So you don't want that happening. So you've had the surgery, you don't want the bile eating up all of that, the incision even, right? So they'll put in a T-tube, and then they'll connect it to a drainage bag, and that will drain the excess bile. Okay, so that helps with healing. So you may see some of these in some patients at some point. Okay, blank slide. Here you have the laparoscopic cholecystectomy. Okay, and there you have the open cholecystectomy. Right, this is what your incisions may look like, and what's your laparoscopic incision may look like. Okay, so just your different structures. All right, so you want to look at your chart in your book. I think it's 30. I don't think it's 30. This is chapter 50. That should be 50-2. Let me just make sure that that's correct. Yeah, so this is 50-2. Sorry about that. Anyway, so after you've had a laparoscopic cholecystectomy, and that's the chart in your book. They're not really talking about the open cholecystectomy so much, but it's all about a laparoscopic cholecystectomy. So I would like you to look at that. So you're inspecting site for drainage, swelling, and redness. Patient can start light exercise like walking soon after the test, like within 24 hours. There should be no heavy lifting. And heavy is considered 5 pounds or more for at least a week. Low-fat diet and regular diet, and then a weight reduction program if that is the case for your patient. The main difference is that with an open cholecystectomy, there's maybe more pain control that's involved because it's a bigger incision that's happened. So maybe they won't get home until 3 to 4 days, and then there's a long recuperation period that needs to happen for them. All right, so then it's just the nursing assessment for your patient with cholelithiasis. So it's just knowing exactly what the dietary habits are, right? And finding out if they're going to need surgery, finding out, if there's bleeding going on. So just doing a whole holistic assessment at whatever level your patient in. It's either in the initial stages where they just had the stones, or it's post-op where they've had surgery, and then you're just monitoring your patient as well as you need to. Potential nursing diagnoses, and once again, these at this point are the same in terms of management. There's nothing new here at all. And then your potential collaborative problems that can happen. So bleeding, especially if the patient has surgery, right? So that could be a complication from that. If your patient has, I don't know, a lot of bile stasis that's going on, where they end up with things like perforations and things like maybe peritonitis, right? So you could even see where that could be a problem in terms of bleeding. So you're just monitoring your patient at all different levels and stages to see what's going on with them. All right, so depending on what your goals were, that's what you're going to focus on. And if they do have a T-tube in place, you're monitoring the site very, very carefully, because remember what bile is, once again, it can eat up your skin integrity. So you want to make sure you're monitoring your patient closely, making sure you're doing all that you can for them. So low Fowler's position as tolerated. So NG or NPO until bowel sounds return. NG may be connected to suction if that's needed in terms of for decompression. Then you're going to advance your diet as tolerated. Analgesia, pain management, turn coughing and deep breathing goes without saying. Splinting to reduce pain. All of that is important for your patient. So key things under gallbladder is know your terminologies, right? So know what the different terminologies are. I know, okay, when we're talking about the stones, am I talking about pigment stones versus cholesterol stones? And then what is our go-to in terms of surgeries? And what is my nursing care post laparoscopic cholecystectomy? So those are the types of things that you're focusing on. What are your risk factors? Is it diet related in terms of stone formation? All right, so what are you going to be teaching your patient? All right, that's pretty much all I had for you under gallbladder.